Okay, welcome everyone. I think we're at a good starting point. We've got a good group of folks already here. I want to introduce Will Bryan, who is our Built Environment Project Manager at SEIA, and he will get us started. And I will, while you start talking, Will, I'll get our presentation going.
Thanks, Sarah. Yeah, it's great to be here with all of you today. Really excited about this topic that we're going to be delving into. For those of you who may be new to SEIA, just a quick overview. We're a 501c3 nonprofit organization, and we really leverage energy efficiency policies at the state and local level to ensure that all people in the Southeast live and work in healthy and resilient buildings, are able to utilize clean and affordable transportation, and can thrive in a robust and equitable economy. And our work really takes place across 11 states of the Southeast, which you can see here on the screen what those are. One of the things that really I think has become central to our work, or at least very important to our work in the last few years, is sort of the emerging role that health plays in the energy sector. In the last 5-6 years, there's been a lot of discussion about the overlaps between energy and health. It's pretty clear that housing in particular is one of the key social determinants of health. And so there's been a lot of conversation about how the energy sector can work to improve the health of residents, not just in the Southeast, but nationwide. And so we've seen, as part of that, we've seen programs that use weatherization to improve kind of the health conditions in the home, beginning to be stood up, throughout the nation, and really beginning to kind of hone in on some of those overlaps between health, housing, and energy. What hasn't really been a part of that conversation, though, is much kind of beyond how energy retrofits can impact occupant health. We know that that's true, but we haven't really been having conversations in a robust way about how the energy sector might be able to work kind of beyond the boundaries of the home, and work with healthcare, and work with insurance, and work with public health in ways that can really impact the health of utility customers and residents nationwide. And so what I'm really excited about today is that we're going to be having that conversation. And I'll just flag that this is part of a series of member-led webinars that SEIA is going to be putting on. This is actually our first, and I think this is a really great webinar to get us started, because it's really kind of innovative work, and I'm really excited to hear more about what Jeff Keller and Face Health are doing. A couple housekeeping notes. We will reserve some time for questions at the end. So if you have any questions, please put those in the chat, and we'll make sure that we get to them. And without further ado, I'm excited to introduce Jeff Keller and let him take it from here. Jeff Keller is the CEO and founder of Phase Health, a company that's dedicated to leveraging non-clinical data sources to pinpoint individuals at risk of poor health outcomes and enabling intervention. And that's what we're going to hear about today. Jeff founded Phase Health when he was previously the Chief Innovation and Strategy Officer of the University of Virginia Health System. His career has spanned finance, technology, and healthcare. He's started 2 companies previously in the healthcare space, and spent several years at General Electric, where he helped to establish corporate venture capital funds in both the energy and healthcare sectors. Jeff holds an MBA from the Johnson Graduate School of Management at Cornell University, a doctorate in cell biology from Vanderbilt, and a BA in biology from the University of Virginia. Jeff lives in Charlottesville, Virginia with his wife and 2 sons, and enjoys spending time outdoors with his family, as well as cooking and dry stack stone masonry. That is something I just learned, so that's fascinating. So without any further ado, I'm happy to turn it over to Jeff, and really look forward to hearing from him and to the conversation afterwards. Thanks, Jeff.
Yeah, thank you, Will, and thank you, Sarah. Thank you to SEIA for hosting this. It's been a great organization for Phase Health so far, just to explore some ideas and always be connected to a really vibrant community of innovative and thoughtful people in the energy space. So this is a great opportunity for us. As Will said, I'm primarily a healthcare professional by background and training. It's where I spent most of my career, with a short detour into the energy sector when I was at GE back in sort of 2007 to 2010 timeframe. And that timing will line up with, as you all know, a lot of the emergence of AMI technology, and obviously sort of the nucleus of this whole conversation. But what I want to talk about today is really this interesting intersection between the energy and healthcare sectors, which are two of the largest sectors of the U.S. economy. As you know, both are facing huge structural challenges, and there are a lot of interesting parallels. I'll get into a little bit of that today, but in the same way that energy has a huge amount of investment in plant property and equipment for generation of power, transmission of power, delivery of power, and is now facing some emerging trends around decarbonization and alternative fuel sources and renewables. A lot of similar echoes are being felt in healthcare that we'll talk about, but I've just noticed the parallels between those spaces. And interestingly here, I think there are some touch points between energy and healthcare where we can potentially kind of kill two birds with one stone and use assets in one sector to solve problems in another. And that's what really Phase Health is founded to do. So let me just give you a little bit of background to level set the conversation. And everyone, I know you probably don't wake up thinking about the healthcare sector, but healthcare in the U.S., as anyone and everyone knows, is a huge dollar spend, upwards of $3.5 trillion per year, and that translates into about $10,700 of healthcare resources consumed per person per year in the United States. This number is inching ever closer to 20% of GDP, and growing at 4 to 5% annually, with some of that growth, depending on the sector you look at, so Medicare, for advantage, even much faster than that. There are huge kind of tectonic forces at work that drive that. One is obviously the aging demographics of the US. We're creating 10,000 new Medicare eligible lives every single day as the baby boomers age out. What that really translates into economically is for folks, I presume most folks are kind of, still waking up and going to work every day on this call. There used to be 4.6 of us for every Medicare beneficiary in 1965 when Congress passed the Medicare legislation. Now there are 2.3. So Medicare is becoming this larger and larger sink for resources to take care of people and keep people healthy. Drug costs are a huge driver as well. I think about 20% of growth comes from the spiraling costs of drugs. Thankfully, a lot of those are getting really way better, and they're more effective, and people live longer and are healthier. The downside is some of those drugs can cost, $10, $20, $50, $200,000 a year to keep people in that healthy zone. And just interestingly, when you kind of think about it, Warren Buffett makes this point that as a percentage of GDP, anyone who gets exercised about corporate tax rates should really sort of set that agitation aside and focus on healthcare instead, because as a percentage of GDP, what we're looking at is 5% medical spend going to 17 or 18%, in the last 30 or 40 years. And that's really going to become a huge economic headwind on the US economy going forward if we don't figure out a better way to solve it. So Sarah, next slide, please. So Phase Health, how do we kind of think about this? As we just said, the US healthcare is unsustainable in its current form due to all these factors and cost drivers. One of the things that really needs to happen, and it's easier said than done, it's a little bit like shifting a carbon-based economy to a renewables-based economy. But in healthcare, that paradigm is shifting from a sick care centered system to a healthcare focused system. So instead of dealing with people once they're at the end of a path of progression of chronic disease, where they're having high acuity, dangerous episodes and encounters with the health system, dealing with type 2 diabetes patients who end up in the emergency room, dealing with people who are hospitalized for chronic conditions because the sort of front end blocking and tackling wasn't done very well or in very good compliance. Those things get very expensive, and they don't have to be that way. A lot of what drives US healthcare costs is actually preventable. It's a matter, however, of getting the right resources to the right patients in a timely fashion so that we can head off those kinds of events. So shifting that paradigm kind of upstream from the very sick, very in distress patient in the emergency room is the idea. One way we think we can do that at Phase Health is through the expanded use of data to really understand the health risks of not just individuals, but of populations as a whole. And that requires broadening the aperture of what the industry has done historically to use data, pull in data from some non-conventional sources, and we'll talk about AMI data as kind of our focus area here, but that's really the thought. So what gives us kind of the confidence here in thinking about AMI data as a potential puzzle piece to solve this problem is that we know there's a very strong link between utility insecurity, energy poverty, and adverse health outcomes. That's been documented by a number of groups and published pretty widely. So we know that linkage exists. There's a certain amount of dollars available to individuals and families every month. They're going to consume some essential resources, including housing, food, energy, and healthcare and clothing, things like that. And a lot of times there are trade-offs that we find when those resources get tight. So thesis number one that we'll kind of focus on today is that AMI data is a determining feature, a correlate of healthcare outcomes, and that we think we can look at, by looking at AMI data, we may be able to identify risk profiles where we would say that residential energy customer or that household has a signature that, when combined with some knowledge of their underlying health conditions, allows us to say this person with COPD or congestive heart failure is likely to do worse than someone with the exact same diagnosis, but whose AMI data shows a much more stable or different pattern. That's thesis one. Thesis two is that utilities can actually play a very significant role in helping to bring that data to bear to solve this problem. Utilizing AMI data in partnership with healthcare providers and potentially payers, insurance companies, to identify those high-risk patients and to get those resources upstream, like we talked about, to make the intervention where it's going to have the greatest impact, keep patients safe, and avoid those downstream high expense costs. Next slide, please, Sarah. So, again, sort of the fact pattern that we observe that gives us confidence is that we know that where people are most of the time is in their home, right? And so one of the things that they're doing in the 70% of time or so that they spend in their house is consuming energy. So we think energy usage actually describes or indirectly reflects a lot about their lifestyle, a lot about the choices they make, a lot about the resources that they have access to, and a lot of the trade-offs that they may be engaging in. We've talked to a number of utilities, including some of the ones on this call. We know, based on utilities who are already doing a lot of outreach to understand, mostly from a non-payment type perspective, that a lot of their customers are resource constrained. In fact, one major investor-owned utility that we've engaged with said, we think a third of our customers right now are resource constrained, i.e. it's hard for them to make that utility payment every month. Therefore, we may see them rationing energy usage in ways that reflects constraints in other parts of their lives. We know that rationing is observable. That again is published data, and we know that rationing is dangerous, right? If you're rationing energy, you're probably also rationing something else. You may not be spending a full clothing budget to keep your kids clothed. You may be cutting pills in half to save on prescription drug costs. You may not be going to the primary care physician because there's a $20 copay. All those kinds of things can play in here. And so energy rationing, we think, is a very interesting area to kind of look at. And we also know that energy is expensive, right? We know how hard it is to go and make a rate case to get increases in our rates as utilities. And that's for good reason, but it's still one of the single largest line item expenses for families and households every month. So we believe that really the decision to consume energy, what you consume, when you consume, how you consume, ties into sort of this almost algorithm that is running in the back of people's minds when they're saying, hey, when is my next payday? What other bills do I have this month? Do I have to put new tires on the car? And that they may actually be reflecting some of those other pressures through energy consumption. And that may be a really good readout of who is resource constrained and at greatest risk. We know also that some of our utility community members are already engaged in very advanced analytic approaches to understanding data. So synthetic disaggregation is an example where you can go from obviously household level energy consumption down to what looks like HVAC, down to what looks like a swimming pool, down to what looks like cooking appliances, and get some additional granularity that would help you from a data science perspective really build out those kinds of signatures that we think are really important. And then finally, we think that despite all that capability, we don't think utilities may know some of these other applications well enough to really bring those assets and those resources to bear to solve these other very expensive, very important problems. And so Phase Health is really here to kind of try to help illuminate and show and educate some of these other opportunities that we think are very addressable. Next slide, please. One before, there we go. So we've talked a little bit about energy and healthcare and the linkage between those two. This is just some data from the EIA a few years back, but essentially showing reports of people who are surveyed and report energy insecurity in terms of difficulty paying bills, have received disconnection notices, and keep homes at an unhealthy or unsafe temperature. So, right, trying to ration that energy, right? This is kind of observable and has been documented and published in the research. And again, we think these aberrant energy usage patterns through AMI data can identify some of those individuals who, if we also know they have underlying health risks, can say this patient, not that patient, is in greatest risk of a dangerous outcome here. Next slide. So just a real world anecdote, and I literally stumbled across this as I was driving to work a couple of years ago. This is from the New York Times Daily podcast, and it had to do with sort of unanticipated healthcare costs that people can run into and some of the ripple effects associated with that. The setup here was that this was a mother of a school-aged child who had some emergency health issues, and the family ended up with, I think, $5,000 or $6,000 of medical costs that they were having to sort of pay out of pocket. I think both parents worked, but not in particularly high-paying sectors, and that healthcare cost was a real burden. And so you see sort of the dialogue here between the interviewer and the mother. And she says, I've not paid my water bill yet. I just keep thinking, please don't turn it off right now, that sort of thing. And then I've got a payment arrangement with the electric because I got a disconnect notice. And so it goes on to say, basically, you're rationing, you're worried about these disconnects because you're trying to make these payments on healthcare. So this is even another flavor of this problem, which is sometimes energy may not be the upstream, the energy bill may not be the upstream cause. There may be a healthcare bill that's upstream of an energy cost. So we think there is this, connection. I won't call it a vicious cycle, but there's definitely an interconnection between energy and healthcare as two very big expenses, where it might be really helpful for the utility who's providing this family's power to say, this person is likely to miss a payment going forward because we know they have a very large healthcare burden. So let's either target some assistance their direction or make sure that we don't disconnect them. That would be sort of against our corporate or community mission. So anyway, just a good illustration that was out in the world. Next slide, please. So one big part of the solution that we think is available and on the table here is the fact that, like we said, this idea of moving healthcare upstream, so not dealing with patients once all these terrible things have transpired, that their chronic conditions have been exacerbated to something that is acute and emergent, but dealing with things in a proactive fashion. And so again, the healthcare system is having to learn this overall, and there's a lot about how hospitals are being contracted with by insurance companies, and doctors are signing new kinds of contracts with insurance companies that get at this sort of a mission. But essentially, what we can say generally is that a huge cost of our healthcare, a huge part of our healthcare spend in this country has to do with what are called ambulatory sensitive conditions. So think of long-term chronic conditions that are widely prevalent throughout the population. So type 2 diabetes, COPD, congestive heart failure, asthma, behavioral health, musculoskeletal chronic pain, obesity, things that literally you could throw a rock, right, and hit, any number of people in a near area, and find a lot of these conditions that are sort of just interspersed throughout the population. These conditions all can be managed to a pretty significant degree if you have a doctor, there's someone checking up on you, following up, making sure you're getting your lab work done, your prescriptions filled, you're taking your meds, whatever those interventions are, right? That stuff is pretty well known. And anyone who has the resources and good access to healthcare can probably do a pretty good job of living a long and healthy life with these diseases. However, we all know that not everyone has resources, not everyone has access to healthcare, not everyone has the healthcare literacy to be able to avail themselves of that. And so a lot of times, one, these things will go undetected for a long period of time. And two, even people who know they have the disease aren't necessarily always in a position to address that or manage that appropriately. And we think that a lot of that unmanaged chronic ambulatory sensitive disease is what drives healthcare spend. And so here we just see a breakdown of emergency room encounters and inpatient admissions, so stays in the hospital, broken down by what some researchers thought was preventable and what was non-preventable. And these are material percentages and carry a lot of cost to the healthcare system, and therefore opportunity for savings if we could do a better job of saying, why is this patient with type 2 diabetes continuing to utilize the emergency room, whereas we know other folks with the exact same condition are well managed, have no incidents, are relatively low cost, and don't have these scary and dangerous episodes. So trying to shift that paradigm a little bit is the idea and the eventual goal. Next slide, please. So how do we make that shift is a really important question. One big part of it is trying to figure out who in that population is at greatest risk. Of all the type 2 diabetes patients in the world, who is at greatest risk of using the emergency room in a preventable way? And that gets into understanding your population in a way that we don't currently. So if you work inside a hospital system like I did, you are very focused on the patients who are coming through your doors every day for whatever reason, delivering the best care that you can. You are less concerned with the members of the general population in the community or the market you serve that you never see. However, you know that people aren't born with COPD, they aren't born with behavioral health, they aren't born with type 2 diabetes. Those things develop over time. And the ability to understand where those things are in the market, or even just focusing on the population that we know and that we see on a regular basis, being able to parse out high risk from low is really important. The way healthcare has done this in the past, and mostly this is insurance companies, is to look at clinical information. So they'll say, Jeff Keller has a high risk of healthcare spend because he has type 2 diabetes. We know he has type 2 diabetes because he's filed a bunch of claims consistent with the type 2 diabetes diagnosis in the past 5 years. We see that because we get the bill. That's fine, but I'm known to the healthcare system if I'm a type 2 diabetes patient. Maybe I go to an endocrinologist once a year. Maybe I'm on metformin. I buy test strips. I have a home glucose monitor. So that's fine, but it describes a known population that the health system's already aware of. We can get beyond that if we start to add in some additional information. And so one thing people are obviously starting to use now is demographics, which helps segment that population further. And even beyond that, sort of where I would say we're getting to today and where Phase Health is headed is towards lifestyle and behavioral data that says, gosh, we can even understand things about healthcare risk if we know that you've registered a car in the state of Georgia, if you have student debt, if you've moved 5 times in the last 6 years. Those kinds of things that are publicly available data sources start to describe some patterns of just life that correlate with risk. And so it may cause somebody in an insurance company to say, hey, I've looked at this, I've seen these populations, I know this particular segment is at high risk. Let's take some resources to try to get upstream and curb spend and prevent those people from what we think are going to be bad outcomes. Next slide, please. And so if we think about, again, those data models that allow the healthcare system to take a much more comprehensive view of not just the patients they know because they're sick, but the patients that they serve broadly as members of a community, you would say, what do you want that data set to do and be, right? What's your dream wish list in terms of the functions and the insights you could gain? We think those data features are listed here on the left-hand side of this chart. And then on the across the x-axis, you start to see some of the types of data that people are using to inform these data models. And so demographics, like we said, consumer behavior, clinicals of the classic, social determinants of health, which Will mentioned early on. And then finally, where we think is a huge opportunity is residential energy usage, right? Residential energy usage is an absolutely objective measure, right? There's no self-reporting. So, you know, for example, when I was at University of Virginia Health System, we would do social determinant surveys and we would ask people when they came in, are you food insecure? Well, I probably have a very different definition of food insecurity than someone who is truly food insecure because I've never experienced that. Secondly, there's a stigma associated with reporting that you may have food insecurity in your household, right? So that sort of subjectivity really kind of compromises the utility of that data. The granularity of it too. So getting down to the household level and you know, obviously in most cases there's, you know, 2-3 people in a household. So you'd have to understand sort of how narrowly it applies to individuals, but understanding the household environment is pretty granular. Available at scale. So in markets where utilities have made these investments and done the hard work of deploying AMI infrastructure, we think we have AMI data available on huge swaths of the population. Furthermore, it's quantitative. So it's comparable from market to market, from household to household. It's not, again, subjective. And longitudinal in real time. So again, to kind of pick on our social determinants questions, we think that, you know, we had a challenge previously in the sense that when we ask someone in a survey who's already in our health system, are you food insecure or how is your, you know, anything, that is a point in time measure. They could walk out the door, lose their job the next day, and everything we know about that person's profile has changed. We're just not aware of it. Versus if you've got something that's longitudinal in real time, like AMI data, you've got a real way to see that. And then standardized and hopefully actionable would be sort of where this is going. So we're not necessarily advocating that you would throw away all your other data sources to understand your population. Just the AMI may be a really powerful complement. Next slide, please. So we're not the first company to talk about collecting data in the home directly on the lives of patients. What you see in a lot of cases, if you go to the big healthcare conferences, is everybody wants to, you know, they want you to use the accelerometer on your phone to measure steps. They want you to, in some cases, put sensors in your home. You know, if I could figure out how many times Jeff opens the refrigerator door in a 24-hour period, that would tell me something about his eating habits. People have talked about you know, sensors under mattresses so I can understand how well and how long someone's sleeping at night. All kinds of things, all of which may be valuable and usable data. The problem is, again, you're targeting those interventions to patient populations that you already know, one, and two, it's expensive. And so what you see most of all is here I've sort of shown for memory care. So for patients living with early stage or even advanced dementia, memory care patients, that's powerful. I've seen a study looking at usage of electric tea kettles in the UK to say, is someone remembering that it's tea time every afternoon at 4 o'clock, or are they missing it by an hour, or are they missing it completely as sort of an indication of dementia progression. Post-discharge, so people who've had a surgery or had a stay in a hospital and are going home, they could be at risk for falls, readmissions, things like that. How are they doing? Those two things are pretty well trodden. They're small populations and it's expensive to do this kind of work. And it's not clear that a lot of this extraneous data really helps. What we would argue is that the beauty of AMI data and the utility infrastructure is that it's already been deployed. Utilities have already put it out in the world for completely different purposes, but it's bought, paid for, up and running today. There's data flowing in, you know, at this very second in a huge number of utilities across the country. So this data exists, is sitting on servers, could be mined for insights that would really help sort of address this problem. And then you can get into much bigger populations because you don't have to go spend, you know, $500 or $5,000 a home to do it, right? You could think about specific use cases like aging in place. You could get into the chronic condition populations. We've talked about the ambulatory sensitive, and you could even just sort of think more generally than that. So that's kind of where we think that the power and scale come from with AMI data for this purpose. Next slide, please. So like everything, COVID-19, has really caused us to rethink a lot about how we deliver healthcare, how people, we see now, we've seen eviction moratoriums, we've seen utility shutoff moratoriums. Most of that has sort of rolled through, but people still have depended heavily on assistance programs. And I think we're still not done seeing the end of that story in terms of how this all pans out. But here's another, sort of great example, from Atlanta, where this woman, a mother of a few kids, had a 13-year-old daughter that relies on a nebulizer to manage her asthma. She lost her work as a result of the pandemic. She's been paying her electric bills out of retirement savings. And at some point, that seems pretty unsustainable. So you can imagine if that family loses their access to power based on their inability to pay a bill, one of the first things that's going to happen in the summertime in Atlanta is that little girl is going to the emergency room with an acute exacerbation of her asthma. And I can guarantee you that there's not an insurance company in the world that wouldn't gladly pay her utility bill for any number of months to keep her away from a $4,000 or $5,000 or $10,000 emergency room visit and possible hospitalization. So in this kind of case, it's really just connecting these dots. AMI data, understanding sort of these payment patterns, people who are at risk, all this stuff really is a leading indicator for what are going to be some big spend, high dollar amount line item expenses for an insurance company down the road, not to mention just the human element of this family having to go through that ordeal. Next slide, please. So let's talk a second. So that's a very human element of this, but utilities in many cases are, investor owned and businesses and have obligations to their shareholders and their regulators. We actually think there is also a powerful business case here. So think about AMI data as an existing asset that's been invested in and paid for by utilities, again, for grid efficiency, for better, more efficient billing, to understand grid operations. But now that asset can be pivoted slightly and used to address a completely other market. So we think that the work that is available here is to really sort of find a utility partner with whom we could go do this proof of concept work to assess the value of AMI data as a source of these risk signatures that we think describe risk in the population. And we think we can do this retrospectively. Once we find those risk signatures, we think we can deploy them prospectively in real-time AMI feeds to say, we noticed a real change in this household, something is going on, someone has moved in, someone's lost a job, whatever it is, something that we think will correlate with, or we've seen in the data will correlate with a dangerous and expensive health outcome. And then we've got an insight that we can use to approach either the insurance company, the payer, or the healthcare provider system. In some cases, those are the same thing, who are responsible for managing those lives and say, hey, it works for us too if you can help us get resources to these patients in a more proactive kind of way. So next slide, please. So for utility partners, we think there are two different kind of buckets of upside here. One is direct economics. We've just done some simple modeling, looking at very, very conservative assumptions about our ability to predict risk and deploy resources. And we think that, there's an easy $25 million of recurring annual revenue to a utility that has 2.5 million residential accounts. And notably, that revenue is at 100% profit margin because you've already bought and paid for the infrastructure to take these measurements. Second, it's recurring, right? Because, risk profiles change, diseases progress, people get better or worse. So if I'm an insurance company, I want an update to that feed. I want to know about changes. I want to know all that stuff. So almost think about this as a recurring, very high margin, incremental piece of business on an asset that you already have. There's a concept called risk-based pricing in healthcare that we think even allows those numbers to go up meaningfully beyond that. And again, all these assumptions are pretty conservative. Indirectly, other things that utilities are already worried about, so a big one being non-payments or service disconnects. both of which are problematic, obviously from a revenue perspective, but also because it generates a cost. It costs money to, turn people's power off and on. It's disruptive. You would love to be able to do a better job of understanding the risk profile of non-payment. So that issue again of the woman whose child had the surgery, right? She was at risk of non-payment because she had a bunch of healthcare spend associated. That would have been visible if you had merged her AMI data with her insurance claims data, right? You would understand that. So we think improved collections is available. And then also where we've gotten a fair amount of positive feedback is just in terms of community relations. I think too often when utilities find themselves on the front pages of newspaper, it's for the wrong reasons. And I live in Central Virginia, and so Dominion just had this very high profile loss with regard to putting a new pipeline over, basically through kind of the middle of the country and some very pretty parts of the state and over the Appalachian Trail. And it was high profile and it was ugly, and it probably didn't do anything to enhance Dominion's standing in the community. But nonetheless, we have a lot of, utility partners who say, look, I would love to be able to, improve my image, to be seen as a helpful member of the community and doing more than just sort of being a monopolist provider of electrons that, seizes people's property when I have a new pipeline or a new transmission line to build. So that's been a place where we've gotten some resonance as well. Next slide, please. So kind of where we are, just to give you a real-time snapshot in terms of Phase Health, we're an early stage company. Like I said, I founded this with a physician co-founder at the University of Virginia Health System. We're really at a point where we need to go prove out and define those risk signatures within the AMI data that we think exist but don't know. And so what we need are essentially two data sets, one being AMI historically and one being healthcare utilization historically, in the same market, on the same population, so that we can merge those together in a de-identified fashion. We recognize a lot of the privacy issues around the usage of AMI data, and then really let our data science team kind of go do the work to say, hey, here's a group of 1,000 type 2 diabetes patients. They over time have had a whole range of outcomes, some of which are quiet as a mouse, very well managed, all the routine visits, but nothing abnormal. And then on the opposite end of the spectrum, a really disturbing profile of high usage, acute encounters with the health system, scary episodes of care. Let's understand controlling for a bunch of other variables around demographics and socioeconomics and those kinds of things. If there's anything in this AMI data that would have tipped us off to this. And if we can come up with those risk signatures, some of which are going to be common from market to market to market, some of which will probably be unique to a market, we think we have then the ability to start to deploy those prospectively. So working with the utility inside their own four walls and inside their data environment to say, if you're monitoring this population for health risk, we'll be able to tell you using some of these signatures, this one, not that one, are at disproportionately high risk, which gives you now a conversation to have with Phase Health and ultimately insurance companies and providers. So we're really looking for those partnerships that would sort of, prove the case that then would allow us to say, now let's sort of do some of this work with some of these more prospective applications and try to figure out how we make this real. So a lot of work left to do at Phase Health. We're excited. One, this is an absolutely huge market. Two, there is a huge human component to getting this right. We think transformation of the healthcare system to a more proactive, insightful, upstream version of what we've had historically is really powerful. And two, we think utilities have this insight and have a lot of capabilities to help make this real. So, I'll stop there. I think that's my final slide, Sarah. But if we've got, questions, I'd love to talk to you more about that. One thing I didn't get too much into here was data privacy and utilization rights. We've given that a lot of thought because we do recognize that's a very sensitive issue for utilities, as it is for healthcare. And I would say healthcare has actually cleared a lot of brush in this space that can be leveraged. So happy to take questions and would love, any follow-up communications from any of the folks on the phone.
Yeah, thank you so much, Jeff. I don't know, Will, if you want to say anything, but you guys are all welcome to type any questions you have into the Q&A at the bottom of your controls of your screen there. So yeah, please question away, or Will, if you have any questions that you want to ask Jeff, go for it.
For sure. Yeah. Thanks, Sarah. Yeah, everybody feel free to shoot us some questions in the Q&A. Jeff, one of the things, well, I have a lot of questions. This was terrific. Thank you. Super fascinating. One of the, I guess, just kind of base level questions that I have, we have some people I think on who are maybe not as familiar with the energy sort of world. And then we have some who are very familiar with the energy world. But for those maybe who aren't, can you just talk a little bit about kind of AMI infrastructure and sort of what types of data you can even get from that? I think that might be helpful.
Yeah, and sorry to skip over that. So, so AMI infrastructure was essentially, there's still places, including Virginia, where it's being deployed. So it's a relatively young technology, but I think the first markets started to see it probably, you guys would know better, maybe 15 years ago, something like that. And essentially the idea is that you take the grid, which has historically been just a one-way highway for electrons going to homes, and you give it sort of a two-way component, and what's going back the other way is information. So power coming to the household, but there's essentially sort of a meter at the home that is not just measuring what's going on, but also communicating that back. So if you think about, if you're old enough to remember, as I certainly am, the utility truck, like rolling up, I grew up in Tennessee, and TVA would, like, the truck would pull up in our driveway randomly, and the guy would get out and walk through the flower beds and go read our meter, and they would take that reading. That's how they would calculate our bill. That doesn't happen anymore in markets with AMI, because every 15 minutes or so, and it varies by market, but every 15 minutes, there's a ping that comes back from the meter on the house to the utility that says the Keller household is consuming 5.8 kilowatts of electricity at this moment. And so if you string together those 15-minute increments over the month, you just sort of take the area under the curve and do the math, and that's basically a proxy for how much energy you consumed, and then you get the bill for that. It's also, there's a bunch of other engineering applications that give people, or give the utility engineers readouts about how the grid is actually performing, and volt var and all kinds of things that I'm not smart enough to understand, but there are some insights that they can gain into grid operations as well. So essentially think of it as kind of two-way communications between the household level consumption and the utilities generating power.
That's great. That's very helpful. Thanks.
Yep. So I always say, my house is like pretty boring, right? We wake up at the same time every morning, kids go to school, we go to work, come home at the same time of the day, showers and baths, dinner, bedtime, everybody's asleep by it. So like my energy consumption pattern is pretty stable. You could imagine, if you had a job loss, if you had a relative who had to come stay with you for some period of time, if you had a $10,000 healthcare bill that show up, you might start consuming energy in ways that started to show deviations from that pattern of normalcy that would say, look, over time, this household's been super stable, and all of a sudden on September 15th, things started to get a little wobbly. We also know there's a COPD patient that lives in that home. Let's just keep an eye on that, right? And maybe that's a call from a nurse manager from your hospital system. Who knows? But those interventions could then sort of spring from insights like that.
Yeah, thank you. Had a question come in about what is your plan to deal with the fact that many insurers will cover a single utility's territory? And then kind of as a follow-up to that, have you determined if you're going to have to go through an IRB process to stand this type of program up?
Yeah, both good questions. So we, for our initial work, this proof of concept, the biggest payers that we can find, the biggest insurance companies we can find, typically in most markets, the utility is bigger than the insurance company. And so, but some markets you do find insurance companies with 60 or even 70% of commercial lives that could be brought to bear. When it comes to kind of going to market, we think that almost all these payers, all these insurance companies buy risk models. And so you would probably go to an entity, or you would build it yourself as Phase Health to say, we have a risk model and anyone in this market could use it. But again, that sort of one-to-one correspondence is very hard to find. So we are trying to look for markets where it's not 50 different payers, each of which has, you know, a few thousand lives in a market. We want a payer that has 30 or 50 or 100,000 lives, so that we can say in one data set from the payer side, coupled with the AMI data, we've got a lot of insights to work from. So that matters. IRB, so, and again, I don't know how familiar your listeners are here, but Institutional Review Board is typically sort of a panel that ensures in a third party sort of arm's length way, any research activities are sort of safe and ethical and respect not just laws and statutes, but kind of ethical considerations for patients under research. IRB is mostly concerned with the usage of identified data. So to the extent that you want to look at Jeff Keller's Dominion Energy AMI data, you would need IRB approval to do that. We think we can navigate that. What's interesting is once we think we find the data element from Dominion Energy and the data element from Aetna Healthcare, and know that both those are Jeff Keller and can marry those things up, I can forget that it was Jeff Keller at all. All I need to know that those two things match together and that this person has congestive heart failure, right? That's all that's really mattered. No identifying information is really important beyond that. So there is a de-identification process. Again, very well understood in the healthcare sector based on a lot of the work that folks in this industry have done around HIPAA and other things like that. So that's a robust space and we think very navigable.
Great. I had another question kind of about the data itself. What types of energy consumption data are most interesting for managing healthcare impacts? And then how can utility programs be helping to collect this type of data?
You know, we really think the residential level, you know, sort of kilowatt, you know, consumption patterns, kind of the 24/7, you know, load curves essentially at the household level over time are what's going to be most descriptive. And if utilities are doing synthetic disaggregation, if there are markets where there are smart appliances, and I know that's still, you know, limited at this point, but if there's the ability to get below the household level and say, hey, this HVAC should look like this, and instead it looks like that, that's more is better in that sense. So to the extent that we become more sophisticated in the algorithms for really, you know, parsing that data further, instead of just saying it's 5.5 kilowatts at 11:15 a.m., if we can really get below that, we think that the more is better. But really, it's not different than what utilities have already. So we wouldn't be asking utility partners to necessarily go do anything new or different.
And it occurs to me, I'm just curious, hadn't really thought of this before, but as part of the kind of data science work that y'all would do, I mean, would you, I'm just curious, like, would you have to take into account sort of, I don't know, age of housing or, you know, other kind of housing characteristics?
Yeah, we think you would want to control for every single variable that you possibly could. So certainly, you know, zip +3, zip +5 kind of stuff, if you can get it, is great. Interestingly, we had some conversations with TVA, and they were filling us in on some of the work that they had done with Oak Ridge National Lab. And Oak Ridge, I guess, had, I believe I'll get this right, and I saw there was maybe somebody from PNNL on the line, so correct me, but they had come up with essentially a model of the built environment in the sort of Chattanooga, Southeast Tennessee area, and every, you know, sort of building by square footage, kind of as a way to sort of think about energy efficiency initiatives and that sort of thing. That kind of data would be fantastic for what we're after, because I think there's so much that's sort of embedded in, where'd you buy a house? What size house did you buy? Are you renting? Are you owning? Right? I mean, there's a lot that's just sort of embedded in more, you know, in more of that. So again, I don't know that AMI as the only piece of data you'd ever look at is enough. I do think that it has a lot of features that other data sets lack. And again, part of that is just this really real-time granular nature of kind of what's going on with people.
That'd be fascinating to see. I think just the, you know, kind of the different profiles too.
Yeah, for sure.
By housing.
Sure. Yeah. You know, the other thing that I should mention here, because I believe there are some folks from utility commissions and regulatory agencies on the line is that a lot of times the regulators in a given market, so whether it's a state utility commission or federal regulator, and the largest insurance payer in the market are both the government, right? So if you look at North Carolina, you look at Tennessee, between state Medicaid, which is a state level responsibility economically, and then the state employees. So North Carolina, I think, has 2 million Medicaid lives and 750,000 state employees, right? That's the biggest chunk of lives in North Carolina as a whole. They're the biggest payer there. They also, through their utility commission, would control sort of permissions to and access to usage of some of this data for this kind of a purpose. So there's a little bit of a, of a complementarity to it where you've got one agency, and granted, it might be a big bureaucratic, complicated agency, but the government is sort of sitting on both sides of this, could solve some of its own problems by using its own assets. So I would note that and, say that's an area of real interest for us. Private insurance companies obviously have a real profit motive. They are being pushed upstream, and there's a lot of ways that that's happening. But, really, when you want to talk scale, like the government is hard to ignore in terms of some of these conversations. So, if I'm just doing my virtual chessboard and say, like, you've got FERC, you've got, HHS, you've got the national labs who are doing are touching a lot of the relevant pieces of this puzzle, right? I think there's a lot that's potentially interesting there.
Yeah, I think we have time for one more question, and we've had one come in. So after you match up the AMI data to health data and then de-identify it, the question is, how do you plan to make an impact on that health condition? It seems that the kind of link between those two would have to remain for the healthcare organization to impact the patient.
Yeah, so, and again, so think about this in the more kind of prospective. So let's say we've done the proof of concept work, we know the signatures, we know what the signatures are. We can now deploy those prospectively and incorporate those into a risk model. If we can say to a provider system, so a healthcare system, a hospital, or an insurance company, listen, this patient lives at 655 Ivy Farm Drive. We know they've got a pre-existing condition, and we know they're showing disturbing patterns in their AMI data that suggest they're at high risk. There are a lot of resources already, kind of in place. A lot of insurance companies have, care coordinators, care managers, prevention programs, things like that. The problem is they don't know how to target them today. So a lot of that preventive care, there's that old saying about advertising that, only 50% of it's effective. You just don't know which 50%. That's a little bit like preventive care right now. There are a lot of resources being thrown at it. It's just where you do the throwing is kind of everything. And so we think almost of the AMI risk signatures as a laser targeting system for where those resources get spent, because they're not infinite, but they're also not super well targeted today. And so as you're seeing, and this is happening at different speed in different markets, North Carolina being a market where a huge push towards expansion of Medicaid, for example, there are a lot of companies springing up to say, let's just do a better job of delivering resources in the community around the primary care type setting, management of chronic conditions, and we'll get paid for it if we do well. Those folks would love this kind of information. They've got the clinical resources to make a difference, and they've got a financial incentive to do the same. So not always, not in all markets, but in some markets, we're really seeing ripe conditions for that.
Thank you so much, Jeff, and thank you so much, Will, for navigating us through this webinar. I think this is a great kickoff of our member-led webinar series. We really appreciate your time today and appreciate everybody coming out and attending. We will have this recording on the website, should be later on today, and we'll send it out to everybody. We'll also include a survey. I'm going to go ahead and link it here in the chat for you guys. We really want to know what you think, and hopefully, whatever feedback you have, so we can continue to improve our series. Let me grab that for you. And then the other thing too is, if you guys want to know more about things that are happening at SIA and you're not already signed up for our newsletter, please do that as well. And I'll put that link also in the chat. So here is the feedback survey. And then last but not least, I know Pamela Fan, our membership director, is on the webinar today, and I would be really remiss to not plug membership. If you are not a current CM member, we encourage you to join. You can do fantastic webinars like this and lots of other great benefits, and I know Pam would love to chat with you about that. So I'll put all those links in the chat for you guys. And I think that's all I have. Will or Jeff, do you want to say anything?
Thank you. Great event. Thanks so much.
All right. Thank you.
All right. Take care.
Bye.